Good afternoon. Welcome to the Washington Institute. I'm Rob Datloff, the director of the Institute, and I'm delighted to welcome you to this very special policy forum event. We are now beginning the third year of the COVID pandemic. COVID has receded from the front pages with the decline of Omicron, and of course, the horrific images of the Russian onslaught on Ukraine, which is itself a topic of a special Washington Institute event on Thursday, namely the Middle Eastern aspects of the Russian aggression on Ukraine. So please do watch your emails for news of that event and tune in on Thursday. COVID is still very much a central feature of life in the Middle East. And as we know, it could reemerge in the form of a new variant and once again dominate all our lives. Now is a good moment, therefore, to take some time and assess how regional governments have done in such key issues as testing, vaccinations, compliance with public health mandates, and to take a look at governments from Morocco to Iran and to ask, are they prepared for what COVID might have in store in the year ahead? I'm really delighted to have a stellar group of experts to discuss the COVID situation across the Middle East. First is Dr. Sharon Alroy-Preis. She is the head of public health services at the Israeli Ministry of Health. Really delighted she could be with us today. Previously, she served as deputy CEO of the Carmel Medical Center and as the state epidemiologist for New Hampshire's Department of Health and Human Services. Thank you, Sharon, for joining us. After her, we will hear from Professor Abraham Flaxman. Now, to comment on the broad swatch of Arab countries, we had planned to host Dr. Ali Muqdad, Director of Middle East Initiatives and a Professor of Health Metrics Sciences at the Institute for Health Metrics and Evaluation based at the University of Washington. But Ali has a family issue that has taken him away from us today. And in his stead, I'm delighted to welcome his colleague on the Middle East COVID team there, Professor Flaxman, the Associate Professor of Global Health and of Global Health Metrics Sciences at University of Washington. And then I will turn to Dr. Kamiar Alaei. Dr. Alaei is an Iranian public health expert who, together with his brother Arash, developed HIV care and prevention efforts in the Islamic Republic before they were arrested and imprisoned. They later left for the United States, where they established the Institute for International Health and Education and closely monitor the situation inside Iran. So Israel, Arab countries, Iran, we're going to try to cover the entire Middle East today. If you have questions for our panelists and you'd like to inject them into our conversation, you have one of two options. Either please use the Q&A function at the bottom of your Zoom panel, or send me an email directly at rsatloff@washingtoninstitute.org. That's RSATLOFF at washingtoninstitute.org. With that, we're going to turn over the program to our panelists, and we'll begin with Dr. Sharon Alroy-Preis from Israel. The floor is yours. You're still on mute. The floor is yours.
And thank you for having me. This is, it's going to be, I think, fascinating discussion looking at different aspects in the Middle East of dealing with COVID. I will share a short presentation on the status in Israel of COVID, especially regarding our policy changes. I think I'm trying to get to the policy changes because this last wave has been completely different from what we've seen before. And it looked like this at the end. This was our fifth wave. You can see that the first one at the beginning of the pandemic was really a tiny blip, if you will. And then we had really three additional waves that were pretty big, but compared to our fifth wave, which was the Omicron, everything else looks really minimal. What I think is important to know about Israel is that we have all the testing done in the country by all the labs connected directly online to the Ministry of Health. So we get all the test results, positive and negative, from pretty early on in the pandemic. And we also get serology tests and antigen tests. So all the testing done around COVID. We have several labs that are doing sequencing. And so we have that information as well. And I'll show you in a minute that information is what we have at the moment. And the other part of really crucial information is knowing the vaccination status of individuals. So everyone vaccinated in Israel, the data is online streamed to the Ministry of Health, regardless of where they got their vaccinations. And the last piece is to know about the status of hospitalized individuals, to know if they're hospitalized for COVID and what is their severity status. So all that information that we built along the pandemic has allowed us to really monitor and analyze our data online and what we are seeing, and I'll show you in a minute how we look at the data. What was crucial for us, and I think will be really important to repeat if there is another wave, is identification of a new variant that is of concern to us and trying to hold on or to hold off before it comes into the country. So most of the threats are coming from abroad. Obviously, there could be an Israeli variant that develops in Israel, but all the variants that were caused any kind of wave came from abroad so far. And it makes sense because most of the people are, we have millions and millions of people around the world. In Israel, we have 9 million. So there is risk of abroad more than in Israel. What you see here is what we've done with our fifth wave. So all these countries were have sequenced Omicron at the same date, which is here, November 20th or 21st. All of us sequenced it at the same date. However, you see here that the rise in Israel cases of Omicron, obviously, was really low at the beginning. And that was due to a policy that change that we will implement, hopefully, if we have another wave, in which when we see a variant of concern coming from abroad, we are trying to close the borders from the countries in which there is increase in that variant or increase in suspicious morbidity from corona, which seems to be related to that, and try to make sure that we have enough time to prepare ourselves. We don't think that this will prevent any variant from coming in. We know it will come in eventually. But we want to hold off in order to have enough time. And the time here that we bought ourselves several weeks in preparation for vaccination, allowing ourselves to have more vaccines available for kids, to have a decision about a fourth vaccine, which I can touch later if you want, to allow ourselves to purchase and distribute to our HMOs medications that were available. And I think most importantly, to have enough information about the variant, how infectious it is, how virulent it is, and to make our decisions based on this. And so if I go back to the previous slide that shows we got to a point where we have really over 10,000 cases per million of confirmed cases a day, it was only because we already knew at that point that this variant is not very virulent. And so in all the other cases, we didn't get to those numbers because we had lockdown, we had vaccination campaigns. In this wave, we knew it was a reasonable risk calculation to allow us to grow to those numbers because the hospitalized individuals in severe and critical conditions would not exceed significantly what we've seen in previous waves. So what we see, I hope you're seeing the slides moving because sometimes in Zoom you're stuck on the first slide. So what we're seeing on a daily basis is a epidemic curve. As you see here, we have PCR and antigen tests as confirmatory tests, and we look on a day-to-day basis how many we have of those. You see that the epi curve is coming down, so we are coming out of this Omicron wave. We also know the number of reinfections, and we also know that this in the Omicron wave was higher than what we've seen in previous waves. We look at the percent of confirmed people tested by PCR, and we can see it on our different testing options. And we calculate the effective R, reproductive number, to see how many people are being infected by one individual. We know that after we changed our policy and not everyone needs to be tested or can be, many people can be tested by a home antigen test, especially those who are vaccinated. So we know we don't see all the picture like that, like we previously have. But when we look at the reproductive number based on hospitalization data, we see it coming down as well. So we know that it's not, it's safe to say that the wave is truly coming down and we have less cases. If you look at the sequencing sample, so at the beginning here, in the previous wave, in the Delta wave, in our fourth wave, we had everything was Delta. Pretty early on in the, you're looking at the last several weeks, most of our cases are Omicron in red, but we're starting to see BA2 in green, and it's expanding. What is truly reassuring is, despite of the fact that it's spreading, it's not causing an increase in the epi curve. So we don't see another surge of disease wave. The wave is coming down, despite the fact that we have a higher percentage of BA2 as the weeks go by. That was from the general population. This is the same for people coming from abroad. It's worth taking a minute to talk about the policy in Israel of travelers. So everyone coming from abroad to Israel, whether they are Israelis or foreign travelers, needs to do a PCR test upon arrival at the entrance to Israel. And then all of the positive results are being sequenced. So we are trying to spot or identify as early as possible if there are variants coming into the country. I would say that we have a close relationship with the Homeland Front in the Israeli Defense Force, and they're helping us with contact tracing of those people coming from abroad and making sure that if we have a variant of concern, trying to break those chains of infections early on. This is what happened with our fifth wave. So we were closing the borders from countries with high rate of infection from Omicron and doing a lot of investigations, intensive investigation to try to isolate those who already came in. Here we have a lot of information about the data in our hospitalized patients. I obviously won't go into that, but you're seeing the severe cases coming down and slowly other parameters going down. But the severe illness is lagging always behind because severe cases are being hospitalized for a longer period of time. So we know from previous waves that it will take longer to see the relief in the hospitals. The Ministry of Health Policy recent updates. So we've shortened the recovery and isolation in Omicron to 5 days. Previously, it was 10 days for confirmed cases, 7 days for people who were in contact, and we have shortened that to 5 days based on data, and I can share that if you would like. We've canceled school children isolation upon contact in order to have kids in schools as much as we can without breaking their routine. And now we are about to cancel isolation requirement for those unvaccinated returning from abroad. For the pharmacological intervention, we have recommended fourth dose to 60 and above. We have done that based on when the Omicron wave was in that period of time of several weeks, when we saw everything happening in other countries, we knew that the wave will come in. At that point in time, we had elderly population that had a booster dose that was about 4 months old, 4 to 5 months old. And we knew that there was waning from the booster from being infected. We did not know yet if that would hold for severe disease, but we knew they had more and more confirmed infections. And so we recommended a 4 booster dose. And we have that information now showing that it was important to reduce their risk of severe infection as well by a factor of 3 to 4. And as you see, we recommended it also for people 18 and above who have either a risk of infecting others or have some kind of occupational risk of getting sick. And the other pharmacological intervention that we have now released in the past several weeks was the passive immunization for high-risk immunocompromised patients. So this is the update from Israel. And I'm happy to give later on, answer any questions you might have.
Terrific. Thank you very much. Really useful. We're going to come back to the Israeli case after we hear about the situation elsewhere in the Middle East. Dr. Flaxman, tell us about some of Israel's neighbors in the Arab world.
Yes, thank you so much for the chance to present. I come today from the Institute for Health Metrics and Evaluation at the University of Washington, and I'm really presenting on behalf of my colleague, Professor Ali Moqdad. Professor Moqdad is the IHME Director of Middle Eastern Initiatives, and I send his regrets. He really wanted to be here to present this to you today, but is unable to because of a family emergency. At the IHME, we have been in the business of making global projections of COVID-19 epidemic for nearly 2 years now. And without belaboring it, I have a slide showing how our models have evolved in 6 separate cycles, starting with what you might consider a conditional projection, what if kind of scenario in March of 2020, to most recently updated in December, of that should be January of 2021, February of 2021, so 6 now, most updated in December of 2021, our model that incorporates new variants, wasting immunity, and booster shots. And so when I tell you about the results in these slides, really I'm telling you about estimates that come from the IHME's COVID-19 projection model that in a very sort of IHME way attempts to integrate all of the available information from all of the places in which we're trying to make estimates. This slide shows you visually how we've got different data represented by different circular dots, in this case for Alabama, United States, on cases, hospitalizations, and deaths, all of which have important information content, but all of which have limitations that we bring together with information on infection detection ratios, hospitalizations, and infection to fatality ratios to estimate what we're really most interested in, shown in this upper right corner, the daily infections, whether or not they were tested for and became confirmed cases, whether or not they progressed to severe disease requiring hospitalization or even leading to death. And the results of all of this number crunching is to be able to say, for example, globally, we have this estimate of our global case curves with peak transmission in March of 2022 with 4.9 million cases per day globally. And with Omicron, with its rapid spread, projected to infect 50 to 60% of the global population. From this global perspective, it's really what happens in China that we believe is going to be a huge influencer of the course of this pandemic, China's efforts to contain Omicron will determine where COVID-19 goes in the near future. A map version showing the entire world represents the estimates we have now of the percent of the population cumulatively infected with COVID. And I'll zoom that in because I know the specific interest of this group in the IHME parlance is in the WHO EMRO, Eastern Mediterranean Regional Office region. Shown here, the colored in countries are this WHO EMRO region. And so when I refer to specific countries, it will be from this subset. When I refer to the region, that's the aggregation of all of these countries. As you can see, there's wide variation in the percent of the population that has been infected with COVID across these countries, according to our estimates. Now, a huge determinant in what happens with COVID is vaccines. Of course, we've had effective vaccines available for over a year now, to some, but there are important elements of both what we think of as supply side constraints and demand side constraints to how much uptake and access to vaccine has been available. And so without going through too many details on all of the hard work my colleagues have been doing to try to make estimates of this, I can show you visually that there is a wide range of vaccine demand globally. And I think I even know how to zoom in on an area of interest to us in this talk to let you see, if you remember, the colors going from orange being low to bluish being high. In the EMRO region, there is also a wide range. And this, we believe, has a lot to do with trust in government, a point that perhaps we'll come back to. But it's not enough just to have the vaccines in arms, because as you heard from our previous speaker, there's also this important elements of waning effect. And when the vaccine was delivered is going to make a big difference. Again, without dragging you through too many of the technical details, my colleagues have worked so hard to have some idea of how these different brands of vaccines have different waning rates and therefore will last longer or shorter against different variants of COVID. Putting it all together, we can get to the important parts, like in the EMRO region, what percent of people do we believe have received at least one dose of the vaccine or have received a full course of the vaccine? And you are here just before March 2022, where our estimate is that about 40% of the population of the EMRO region has received at least one dose, has received a full course of the vaccine. The implications of that, combined with how many people have been exposed to the COVID virus and therefore have developed some immunity from exposure to the virus instead of developing immunity based on having access to the vaccine, is shown on this slide, where again, for the EMRO region, our estimate is that you are here in this March grid line, 60% of the population has protection from Omicron. And you can see that we believe as this wave of the outbreak continues, some amount more will become protected. And then as time goes on, this waning of immunity will lead that to come back down somewhat. I thought in this audience, there might be particular interest in an element of data collection that my colleagues have worked very hard on to understand what different government responses have been to COVID. And so you can see in this slide about a third of the table that's in our regularly produced report on this matter, showing country by country in the EMRO region, colored in squares, indicating whether they are or are not trying different approaches to limit the spread of COVID. And so you can see, for example, in Palestine, there are mandates closing primary, secondary, and higher education school settings to limit spread, while in a number of countries listed on the right of this slide, there are not currently educational mandates in place. And now that I told you how to interpret this, I'll let you digest it just a little bit more before flipping to the next slide, because one of the most important mandates we have found is requiring the wearing of masks. And you can see that across the EMRO region, there is a lot of mask mandate in place, including some places that even have a monetary penalty, a mask mandate fine, saying if you don't do this, there will be consequences. Of course, this is about what rules are on the books, and there is still substantial heterogeneity in how these are enforced in practice. So one of the goals in our work is to understand, based on what rules are in place, how things are going to change in terms of the spread of the virus. To cut to the chase of what we find from all of this, you are here. We think that projected daily cases will continue to go down, not at the high clip that we have seen up till now. It's been wonderful to see them go down as we've exited the Omicron wave, but that they will continue to go down through the spring and into the summer. And therefore, we project that reported deaths will also be going down. Now, remember, you are here, so we are still seeing a substantial amount of daily death coming from this Omicron wave, and that's because of the way these worse outcomes lag behind the infections and therefore confirmed cases. And so in summary, I would say, looking forwards, timing of vaccination for at-risk populations is one of the most important things to be looking at. As I mentioned, seasonality has been a very important part of our model, and with the combined winter seasonality and timing of vaccination and waning means that there is still a risk of future outbreaks, especially in winter, combined with this vaccine waning. More widespread use of boosters could potentially attenuate the impact of this waning immunity. And finally, masks work, and this winter surge will be profoundly affected by winter mask usage. Furthermore, Omicron's rapid spread and the low severity of Omicron has produced a high level of immunity across the region, and vaccination does remain very low in some of these countries. So the numbers quoted for the whole region mask substantial heterogeneity. Now, the impact on the economy and health will be tremendous in many of these countries, especially where they have already been suffering from unrest and wars. And finally, we believe that excess mortality is much higher than what reported mortality has been. And so I showed you a sort of reported death per day projection curve a few slides ago, but we believe by looking at excess deaths that there are perhaps as many as 1.8 million deaths from COVID in the EMRO region. I will leave it there. Thank you so much for the chance to present.
Excellent. Thank you. Lots to think about. And we're going to come back to many of the points that you raised in just a few minutes. We're now going to turn to a discussion on Iran with Dr. Kamiar Alaei. Dr. Alaei, the floor is yours. And actually, just before I do that, let me remind everyone, if you have questions, please feel free to send them using the Zoom function, the Q&A function on your Zoom bar, or email them to me directly at rsatloff@washingtoninstitute.org. Okay, Dr. Alaei, the floor is yours.
Thank you very much. Hello, everyone. I'm so honored and delighted to be here. I want to give you an overview of the COVID situation in Iran from the beginning and the lesson learned. So the first question, when we talk about COVID and some countries like Iran who have been significantly affected, is due to the infrastructure of the healthcare system, or maybe this is something else that we may find over this presentation. As you know, we have a very well-established health system in Iran. And interestingly, Department of Health is part of the medical university, which means there is a very close collaboration between the Commissioner of Health and the Chancellor of Medical University, and doctors and nurses and students and residents, they have a rotation to go to visit those facilities. And we have a very robust infrastructure. We have in each single rural area a health post. We have 60,000 trained staff working in those rural areas. And if we look at the other health indicators beside COVID and the facilities, as you see over the past 40 years, the number of health facilities were increased, and even per capita, the number of hospital beds were increased. So it shows that significantly we had a growth in infrastructure of regarding number of beds, number of physicians, nurses, among others. So the point is, this is not about the capacity. And if you look at other vaccinations, just give you an example, for polio, we have a very good coverage, almost 99%. And this is the case for most of the communicable diseases, which means before COVID, we have a very robust system, and we had a very strong cold chain for any vaccination, that if there was any outbreak, in a few days, in any single rural area, they could have access to those vaccines. So then the question is, what happened during the COVID? And if you look at other health, indicators like neonatal mortality, maternal mortality over the time was significantly decreased, which means really the capacity of the health coverage was significant. And even if you compare Iran with Turkey, that we really took Turkey and Iran, you can compare the system. The trend was, reducing those, maternal mortality and neonatal mortality was decreasing significantly. But if you look at the health disparity in Iran, unfortunately, there are some areas that they are underserved. And that's the point, that the question is, if we get hit with COVID-19, whether those challenges are only limited or restricted in those rural areas, or this is something nationwide. Because if it is nationwide, maybe this is something not related to the current situation of physical or physical barriers. So then the question is when, how, and why the virus entered the country and what happened. So if you, like back 2 years ago and compared to other countries that they started to reporting the new cases, in Iran, the situation was worse in the entire region. And one of the main reasons was that they politicized a non-political health concern from the beginning. They thought if they admit that they are affected by COVID, they may be tagged by other countries. And unfortunately, the first few cases was during some important events in Iran that they didn't want to admit because they thought maybe people, they don't come to support the government. And that was the beginning of the first time in the history of Iran for over 1,400 years that there was really no conversation between scientific group and stakeholders. And that was the part that militia took over. And unfortunately, they took control of all the decision makings. And that was the situation in a country with a very robust healthcare infrastructure. We was the most affected country by COVID. And there was a significant controversy over the time. For example, as initial reaction of policymakers was huge silence, and over the time, they wanted to take advantage and say that we can control it, but instead of using an evidence-based approach, for example, even militarily, they said we found a device that we can track COVID within 5 seconds from 200 meters. And over the time, surprisingly, there were like over 10 organizations that they admitted we have a new vaccines. And that was for the first time that the Supreme Leader opposed to receive any vaccines like from Pfizer, Moderna, and AstraZeneca. And I think that was a message we learned, that how the Supreme Leader was misinformed by some part of the militia. And that was a really direct message that delayed 5 months access of people to vaccine. And that was the reason we showed that this had significant increased number of mortality and morbidity, which we could easily cover. And really the health system was dysfunctional, that they couldn't use any of those, structured system, to provide those vaccination. And also the majority of the data during the first, year was underreported significantly. And then they started to change and be more transparent. But unfortunately, regarding the vaccines, until we had a new government like 6 months ago, it's still, there was a kind of push against, getting any of the vaccines from outside. And I think one of the main reasons to delaying to receive vaccine was wanted to create time for people to use internal vaccine, which was, we didn't know even what is the efficiency or effectiveness of the vaccine. And also budget allocation. We know that after a few months, there was a debate and finally approved to allocate 1 billion euros to dedicate to vaccines. But unfortunately, most of that was used for something was not very robust. And there are a lot of recently report about that I don't want to go to the details. But during the past 6 months, I think there was a significant shift for the policy, because the new government wanted to show to the society that they wanted to support the people, and they realized the previous policy failed completely. So today, when we look at the data, the reported cases is 137,000, but we believe this is underreported. If we use excess deaths, at least this is 3 times more than this. We get up to like 450,000 of death cases. And also definitely total reported cases. This is significantly underreported, and at least it may be 5 times greater than this number. And if we look at this trend, initially, as you see, it was underreported, and over the time there was more transparency. And today we see the trend is increasing. But if we look at over the past months, is up and down, because we know we were affected by Omicron, which was really expecting that the number will be increasing over the time, and the number of deaths is not as high as other like beta or delta. But the point is that now they are getting to be more transparent. The number of vaccination coverage is increasing. Look at in 6 months, 75% of population, they got the first dose, and 66% they got the second dose, and 27% the third dose, which means when they decided to make that political will, they were easily able to cover the entire country within a very short period of time. And this is the lesson we learn, which means how we learn from the case studies of other countries. We know there are a lot of countries at the beginning, they made some political decisions, but over the time they changed the agenda and they were more transparent and more collaborative. So I hope this is a time for the region in the Middle East. We have more collaboration and dialogue. And what are those that prohibited us to have more collaboration was lack of trust. Unfortunately, it was trust even between the society and the governments. When you see there are some internal vaccines, there are very minimum willingness by society to take those internal vaccines. And then lack of transparency that over the time is getting better, and unequal access that I discussed, and unsustainable policy. As you see, significantly there was a shift and change in those policies, but it's getting a little better because now they got more accountable by the society through social media, that they ask for more transparency and more evidence-based data. And definitely it's very important to see how we can prioritize health policies, because if you look at the Islam over the past 1,400 years, even during Prophet Muhammad, the top medical doctor was a Jewish. He learned and trusted him. And if you look at a lot of statements that if you want to learn science, go to China. This is 1,400 years ago, and learn from a person who doesn't believe God. And this is point when we talk about health. we shouldn't politicize that. And even we wanted to listen to doctors' advice. And this is what a famous statement say, al-ilmul ilman, ilmul adyan, and ilmul abdan, which means really when it comes to medicine, we have to trust doctors and health policymakers rather than politicizing a non-political issue. Thank you very much.
Fascinating. Thank you very much. There are some really interesting overlaps between some of your comments, and I want to explore some of this in a question and answer discussion now. And again, drawing on some of the questions that I'm getting online and directly to my email. One interesting theme that I heard common to presentations from Dr. Flaxman and Dr. Alaei had to do with the question of trust in government and the extent to which citizens around the region have confidence in the openness, the honesty, and the directness of their government to address their health concerns. So first, can we say a bit more about this? How much of this has been an impediment? And then in Israel, is this also an issue, or is this has this current Israeli government been able to overcome whatever hesitations there may have been in terms of popular reluctance to follow mandates from by government order? So let's take a look at the question of trust in government and the extent to which that is a factor in following public health directives. Start with Dr. Flaxman.
Yeah, thanks for calling back to this one. It is one of these things that when we say it makes perfect sense. If there are things that a government can do that are going to reduce the spread of a pandemic, and the people have more trust in government, they're going to be more willing to do these things. And conversely, less trust, less willing to do these things. A colleague of ours, Tom Boyke from the Council for Foreign Relations, led some work using IHME's estimates to investigate this systematically. And so it makes logical sense. And it also now has some very quantified values that were published in his work in Lancet pretty recently, saying that, and I'll try to quote you a number, increase in trust of governments such that all countries had societies that attained at least as much trust in government as in the 75th percentile highest trust in government, which happens to be in Denmark. This could have reduced global infections by 12.9% for trusting government and 40% for trusting interpersonally. And these are all made precise in this work, but I just wanted to lead with this kind of quantification of this, what in hindsight is a very intuitive idea. And then I was so interested to hear it connected up with a very specific experience that Dr. Alaei was mentioning in the case of Iran.
If I could just press you for a moment, since you gave us the good number for Denmark, can you give us some of the, I mean, you don't have to give us all 20 or so, but a couple of numbers in the Middle East and where that relates to what the positive number we heard in Denmark?
I wish that I had the memory ready to rattle those off. Let me look them up for you. Okay.
All right, we'll come back. Dr. Alroy-Preis, can you say a word about how the Israelis are dealing with the question of trust in government?
I think it's a very difficult question. We had a shift in our government midway in the pandemic from one to another. The current government is actually a government that is based on several different parties, so that's a challenge by itself. But I think the main thing to me is obviously there is an importance in the trust in government and the trust in the Ministry of Health, to that matter, not just the government, but the bodies who are giving recommendations. But I think really part of it is pandemic fatigue over time, is that you can give certain recommendations at a certain period of time at the beginning. And then later on, people after a year and a half, 2 years into the pandemic, it's very difficult for all of us to follow those instructions. And so we need to bear in mind when we're giving those recommendations, what is something that is really crucial, and we need to explain it to the public, and what will be very difficult to follow. And I think to some extent is the trust in the government and in the governmental bodies, and to some extent it's just the pandemic fatigue over time.
Okay, thank you. Now, Dr. Alaei, you implied that that trust in government has gone up in the last few months as government has been more responsible in disseminating vaccines and embracing more global norms on this issue, which is a bit fascinating from an outsider, given that one thought that that Iran has elected a more ideologically hardline government to replace a government that one normally describes as, sort of more moderate, as it were. I know these terms don't really translate very well or very conclusively. Why do you think the current government has focused in this direction? And is it really to repair this perception of lack of trust?
So there's no increased trust from society to the governments. But the point is that the government had no other options, because when they took over, it was during the worst situation of COVID. And really, this government was part of those that they were opposed against vaccines. Even the current Minister of Health was one of these doctors that say we shouldn't get any vaccine inside. But it's very interesting how they dramatically shift and be very pro-vaccines, which means in Iran, surprisingly, those things that are red line can change very dramatically in a very short period of time. And this is a lesson we learn and we can apply to other issues, which means they realized that they lost their reputation and now they wanted to say to the society, we want to serve you. Economic situation is terrible. The only thing that they can see is what is the tangible for people is to reduce the mortality. And that was the reason I think they completely shift and got very involved in vaccination. But the point is that this is first time over the past 2 years that people, they don't trust about any message comes from Ministry of Health. Before that, it was completely opposite, which means if people, they need to get any information, they reach out to the Department of Health, the website. But now due to what happened over the past 2 years for COVID, and it's very interesting, the lesson learned from COVID is whatever wrong decision they made within 2-3 weeks, there was a disaster situation. It's different than other policies which may take few years. Say, oh, we are good in COVID, and 2 weeks, that was huge increase, or vaccines are effective. In a few weeks, they see it's not. So that was very important, that how they became more accountable. And I think this is very important to consider and to apply to other issues. And, for example, a lot of people reach out to us and other doctors outside of Iran, even for checking which vaccine should be used. If this message came from Minister of Health, should we trust or not? And this is, I think, will remain for a while because it's hard and people side. There's no single family member who haven't been affected by COVID. So this is really tangible, and it was extended to some of the followers of the government that they came and say, oh, I lost my, parents, my family members due to this, mismanagement. And this is the key point that, make the government more accountable.
Okay, very good. Thank you. Let me ask at the other end of the spectrum on a phenomenon that we regrettably suffer from terribly here in the United States, in some pockets of our country, which is COVID disinformation, purposeful disinformation, rejection of science, this sort of thing. How common is this in your countries? And how effective are governments? I mean, are governments complicit? We just heard you, Dr. Alaei, imply that at certain times government is actually complicit in being sort of counter science. But even when government isn't complicit, are governments being effective in responding and addressing this? Where does it come from? Does it come from the far right, the far left, some ideological source, or a general distaste for science? And how serious a problem is this from a public health perspective in trying to get your societies to do what they should be doing? Dr. Sharon Alroy-Preis, I saw you nodding a few times there.
Yeah, I think this is one of the biggest challenges here in this pandemic is the fake news. We have been dealing with this for a year and a half now. And since it started before the vaccinations with anti-masks and other measures, trying to say that this virus is nothing, it's like influenza or less. It doesn't even exist. So it went to the very extreme of completely disregarding this. And obviously when the vaccines came in, it became worse with a lot of fake news around the vaccines, around their safety, around their efficacy, effectiveness. I think this is one of the biggest challenges in our days with social media, when it is so easy to just spread fake news. And it's hard for us to sort of chase it, because even when we're trying to chase it, we're not sure we're getting to all the places where it has already spread. So our government saw it as one of the crucial things to fight. We are trying to deal with this by tracking social media. And every time that there is something that is fake news, trying to put a label on it, fake news, and explain the real data and the science that is available behind it. What we're doing in the Ministry of Health is updating our data on safety and effectiveness as much as we can. All the data about the pandemic epi data is on site. So people can look at the data, investigators and others. So it's pretty available, and we're trying for the real data to be as accessible as possible. But it's a huge challenge, and I'm sure we can do better with dealing with fake news. We're trying to break our heads how to do it better all the time.
Have you had sort of national organized campaigns against vaccination mandates that you see in some parts of the United States and elsewhere?
It wasn't, it was, yes, we had campaigns by different groups of people who would do campaigns and videos and signboards. Yes. And part of it was even led by some physician groups. And so it was really challenging to try to overcome that with the real data, the good and the things that we don't know about the vaccines. But it was kind of shifting all the attentions to things that are either not true or not known. And they're switching it around to make it seem like the vaccines are not safe and the disease is not severe and there's nothing to it and all kinds of those things. So yes, we had national.
And Dr. Flaxman, in Arab countries, can you talk a bit about to the extent there exists this reluctance or disinformation campaign? Which countries have been more amenable to this than others, more receptive? Which countries have sort of stuck with whatever the governments have been telling them that they need to do?
I am only prepared to comment in the broadest generality about all of this, but I do think it's useful to distinguish between misinformation, getting things wrong in a dangerous way, and disinformation, when people are doing it intentionally for their own strategic reasons. This has been a huge challenge, both of these, globally during the COVID-19 outbreak, but it's not new. And I think there's a really valuable project called the Vaccine Confidence Project that has been looking at vaccine hesitancy and the mis and disinformation behind it for a number of years. The broadest takeaway from that I think is really important to keep in mind is there are so many different reasons for disinformation, misinformation, and more broadly, vaccine hesitancy. And so it really behooves us to get specific, not just even about a country, but even about specific groups in a country. When you think about why was there vaccine hesitancy around the measles vaccines in the United States a decade ago, you're going to get a very different answer if you're talking to evangelical families versus Orthodox Jewish community versus other groups that have been rejecting opportunities to get vaccines. I think we have to carry that into these broader contexts as well. And so very interested to hear what other colleagues on the panel have been observing in the areas in which they're expert. Thanks.
Thank you. And Dr. Alaei, purposeful disinformation, not from the government, but from parts of society. How common is that in Iran?
So it was not very common. There was a very minority group of, very conservative groups that they wanted to promote some, approaches which was used 1,400 years ago as the only way of, treating COVID. And some of those leaders, they died due to COVID. So means I was not very worried because the majority of society opposed to those really minorities. But initially there was some, disinformation by the government against, Pfizer, Moderna, and AstraZeneca that over the time that completely changed. And it's very interesting that most of the society of Iran follow social media and they follow really, outside of Iran messages. So it means they are not significantly influenced by those initial propaganda, but the challenge was more about mistrust than misinformation.
Okay, I have to ask you just a basic question about your confidence level in the statistics. I've traveled to almost all of your countries over the last year, from Egypt to Jordan to Israel to UAE, and I've seen all sorts of different compliance with mask mandates and vaccinations, and I'm totally befuddled that some countries aren't just way further off the charts than the numbers suggest, given that there's so little compliance in some parts of the region with mask mandates and that sort of thing. How confident are we in the numbers that we think that we have? And I guess this is essentially for you, Dr. Flaxman.
Oh, well, cut me off when you've heard enough, because I could talk about this for days. But in short, it is shocking how little we know about these things that are so important. The main source of information about how many people are wearing masks comes from asking people. And of course, that is going to be biased by all of the socially desirable elements of asking that. And it's going to be biased by the people who are willing to answer when they're asked. So the best we can do is triangulate between multiple alternative sources and say, oh, this just doesn't add up. As you heard from Dr. Alaei, and as I alluded to, the most basic things, such as the number of deaths daily due to COVID, are things that we know have inaccuracies. And perhaps only 1 out of 3 deaths due to COVID are being counted as COVID deaths in some places. So every one of these sources, I think, has its limitations. And as someone who loves working with math, stats, and numbers, this is a great business to be in because there's so much work to do trying to trade them off against each other to make their strengths complementary and address their weaknesses. But when it comes to making choices, this is a huge challenge And it's a huge challenge because I think when we scientists start talking about how much uncertainty we've quantified and what a fun challenge it has been to say it's between here and between here, and this is how sure we are about that, what happens in policy? It's easy to say, well, we need more information. And so we're not going to do anything based on the science while we wait for it to get more sure. But we know that things will help. And so this is the consistent challenge. How do we say what we know will help and still be true to all of the hard work in science of quantifying our unknowns?
Okay. Anybody else want to comment on our confidence in the data?
I think definitely that's a very challenging issues, but when it comes to Iran, is more from the message comes from the government that they say, oh, we have to shut down and be very careful based on data. But when it comes to a political day or political event, they say, no, everything is open. What happened? A week ago, you said everything should be shut down. It's really challenging that over the 2 years, people just gave up. And that's, I think, the challenge. It's more than like about the way, whether they wear mask or not, they just say maybe we don't know who is right and who is wrong, and they get confused. And definitely if some of them, they don't wear mask, and it will like affect the rest.
So, let's go in our last 10 minutes or so and talk about the future. Talk about preparedness for the next round. Hopefully one doesn't come, but preparedness for a future round. To talk a bit about, for example, in Israel's case, the permeability between Israel, the West Bank, people coming back and forth, and how that is a factor in what you're doing to control that. So let's take a look at the future and how confident you are that you have put in place policies and procedures that at least limit what the damage that a future might look like in your areas. Let's go backwards. I'll start with Dr. Alaei.
Sure, definitely it's hard to predict the future, and as we know, you never know what will happen for the next mutation. But I think there are a lot of lessons we learned that I think all the countries, they have to work together, particularly in the Middle East, that we have a lot of countries that they have a lot of resources, but the point is that how they can collaborate with each other, because we know if one country will do the best, but the border countries, they don't do the best, definitely we have new mutations. So definitely I think I call for more collaboration and a political partnership, across the region, to be prepared for the new mutation of, COVID-19. And the other thing is how we can have more, a timely response. Lesson learned from Taiwan. As you know, back in 2002, when we had SARS, Taiwan was really affected, but they made a very well-established system. So when China hit with COVID, they immediately responded and they were able to manage it very well. I think this is the lesson we learn, how we can work together and be prepared for the next pandemic.
All right, Dr. Flaxman, preparedness.
Yes, it's what's on everyone's mind, I think. And there's the adage, hope for the best, but prepare for, well, now that we've seen how bad the worst can be, what is the appropriate target to prepare for? So I'm thinking about, even in the best case, if the future of COVID is a Omicron-like, very spreadable, but not as severe sort of virus, well, we've still got so much to build back from. Of course, if a new variant emerges that is more deadly, it's going to change the game again. And so first and foremost, we must be thinking about vaccines for those who want them but haven't yet had access. That is going to forestall these sorts of variants in general, therefore be an important way to avoid the risk of some more virulent reemergence. But as we shore this up, we've got to be thinking about our healthcare workforce. Think about the doctors and nurses and hospital systems that have been suffering under this incredible strain for the last 2 years, some of which were on pretty shaky foundations to begin with. And I think that this connects to Dr. Alaei's point about training and about building these sorts of cohorts across borders. As these viruses have demonstrated, the disease doesn't care where the borders are. And so we need to really be thinking about this kind of rebuilding. And in that same way, I think if we're in an Omicron sort of setting going forwards, we need to also be thinking about deferred care. How many people had something that they would have gone to see their doctor about, but it was COVID and they didn't go, and they've been suffering from it getting worse up till now? What kind of strain is that going to put on our already stressed health systems going forwards? So that's what's on my mind. And again, very interested to hear from the others how it fits.
Thank you, Dr. Alroy-Preis. And you have, as I said earlier, you have a sort of a unique situation given a somewhat permeable border with the West Bank. Preparedness.
So I think because of this permeable border, we thought early on that we could not actually approach COVID-19 pandemic like New Zealand, even though we have one place where we can fly off from. Still, we're not an island, and we cannot really disconnect ourselves from all the rest, for the better and for the good. We've done some things with the Palestinian Authority with vaccinations and such. I don't want to go into that. I think we can do even more than that. But looking into the future, 2 years into the pandemic, I think the biggest challenge is trying to translate this phrase that is keep on being thrown to us. Let's live with COVID. What does live with COVID mean? So I think living with COVID means that we're trying to keep things as open as possible. But for that, we need to have a lot of testing done to know where we are with the disease, where it's going up or down. I think we've learned a lot about the how crucial online data is for infection, for testing results, for vaccinations, for the status of hospitalized individuals. We need that data on a daily basis updated so we can make decisions that are in real time and not in hindsight. And we've learned that our healthcare system is very unique, and I'm very proud to be part of this system. But I think the Israeli healthcare system, public healthcare system, is very unique. We've went through 5 waves and had a lot of hospitalized individuals in the hospitals, also at home. It has a huge burden on our healthcare workers, and we need to see how we bring resilience back to them, not just training, but make sure that we strengthen them. They're after 2 years where they've vaccinated, they treated both in hospitals and outside of hospitals. In addition to that, they treated all the rest. So I think in the first and maybe second wave, people hesitated from coming to care with other things. In the third wave, it disappeared. So we were treating everything and COVID. And so I think our healthcare workers, we need to bring something back to them. They really held the fort in this 5th wave without closing anything. And it was due to their resilience that we were able to do that. Looking forward, we need to make sure that we have our eyes on the ball, and the ball is the foreign travelers and Israelis coming from abroad, not just tourists, but the borders. How do we keep our borders as safe as possible? And with living with COVID, allowing people to travel and allowing travelers and tourists to come in and without isolation. So there is some balance here. and we need to make sure that we figure out the right balance. I'm not sure we're there. We're just opening our tourism now, and hopefully this will go smoothly. But we are trying to find that balance where we have enough sensors, both in our community and in our borders, and in the world, to know when something is wrong and raise flags and act quickly upon it. When you talked about the lack of data, we have data that could be better in Israel, but part of what is challenging is trying to monitor the world and see what variant is coming from where and where do we need to do something about it. And the data from the world is lacking in a lot of places. And so we can close, for example, our borders to people from countries who are just sequencing better than others. But that doesn't mean that that variant is more prevalent there. They're just finding it because they're doing a good job sequencing. So that part is really challenging. But I think in Israel, we are actually looking beyond COVID and trying to build a health radar that would look and try to find the risk for the health risks, very similar to what we do in security in other areas. What we realized is that everything that we build for COVID-19, the testing that runs online, the vaccination that runs online, the status of hospitalized patients that are online, are only for COVID. And if we have, let's say in 2 to 3 years, another pandemic, we're starting from scratch, and we really can't afford that. So we need to build a system where similar data is being shared online, and it's going to be very challenging to build that system, but that is our vision now, to try to make sure that Israel is prepared for the next pandemic, not just the next wave of COVID, but in general, making sure that we identify early on health threats and try to mitigate them when they're small.
Terrific. That sounds like quite a challenge. I'm afraid that we've run out of time. I do want to thank all of you, and I just want to echo something that a number of you just said a moment ago, that regardless of the issues of trust in government or disinformation across Iran, Arab countries, Israel, surely healthcare workers have been on the front lines, responsible for their countries, their societies, their peoples, and in whether it's in Farsi or in Hebrew or in Arabic, they all are doing the same job. So let's all salute them. Thank you all very much. Thank you for joining us for this fascinating discussion on the present and the future of fighting COVID across the Middle East. Thank you. Bye-bye.
Thank you.